Okay, so I decided to do this presentation in a slightly different way. So it's not going to be like slides and then discussion, but it's going to be case, very quick discussion with each of you and even the audience. And then if we have more time, and then I have some slides at the end as like a sum up. So these are not super complex cases, but they are cases in which we show the role of the epithelium. In most of them, you will not see the epithelium at the beginning. So don't ask, because it's going to be at the end. But I have in all of them, all right? Because I know Danny will say, show me the epithelium. All right, so this is first case. So it's a patient that was referred to me as a unilateral keratoconus with a gradual but quick reduction in 6 months of vision, 49 years old, which already sounds like strange, and it was already considered for cross-link. So I'm going to show you a 4 maps tomography with the MS-39 without the epithelial map. So obviously the wrong eye is the right one, in which you have this inferior steepening, and the left eye looks normal. So who would say in this room that this in the right eye is, without the epithelial map, is a keratoconus? So you have anterior, posterior elevation, you have everything except the epithelium. I wanted to discuss with you that it's because I really like that we have a lot of tools that are amazing, and I will show you the epithelium in 1 second, but we have to always keep our mind that we have things that are amazing, like posterior elevation, sometimes we don't look at them. So that's the epithelial map. That's another thing I wanted to show. So here the epithelium you see is red, and I did it on purpose because one issue that we have in the MS-39 that you can switch the color scale and you can have it either blue or red. So the thick epithelium can either blue or red, and that's a problem because dangerous things are red, but this is not dangerous because it's a thick epithelium. So I really suggest that you switch the scale to opposite, that the thick epithelium is blue. Because if you have a keratoconus, a blue epithelium is not a keratoconus. So anyway, you can clearly see that it's a very thick epithelium. So I go back to the patient and I say, there is something you didn't tell me, because the cornea was crystal clear. And she said, actually, almost 1 year ago, there was a drop of boiling oil that went to the eye. She didn't have a decrease of vision, so she didn't think about it. And after months and months of epithelial hyperplasia, she got this. And they say, I'm just going to remove your epithelium. And I was speaking about the fact that the epithelium in corneal ectasia is thin when compared to astigmatism, where this is thick. And this is the post-op. So the patient was 20/20 unaided, just removing the epithelium with alcohol. Obviously, it's still thickish because probably some of the stroma was lost with the boiling oil. But this is the beauty of showing how important is the epithelium, because, well, probably even if they would have done cross-linking, they would have done the same, because they removed the epithelium, but it was a completely useless procedure. So that was the first case to discuss about epithelium. This is a second, more complex case. So this was a +4, +5 LASIK done many years ago in 2009, with 4 retouches and flap lift, and sent for ectasia. With a very poor vision. There was a very clear epithelial ingrowth inside, so you always have, the issue that you have steepening because the patient is obviously after hyperopic ablation. You have also the epithelial ingrowth, and 4 retouches, it's increasing the risk of ectasia. So I'm going to show you the examination. You can see that there is a clear steepening in the center. I show you the epithelial ingrowth just to make sure that it's clear that there was epithelial ingrowth, but not in the place of increased tangential curvature. So here again, we don't have the epithelium. Well, we have it, but we will see it later. So you have anterior elevation, that is a red spot. I didn't want to place it there because there were too many images. I placed posterior elevation and I placed corneal thickness. So since you have seen this, and then I will come again. So is it ectasia or not? I place it back so you can think about it. Is it ectasia or not? Who thinks it's ectasia? Who thinks it's not ectasia?
Posterior looks too good.
It's not ectasia, right? Exactly. So, and here I wanted to show you the epithelium. So obviously, how do you treat a patient like this? Because we really need a very, the epithelium. And we need OCT epithelial maps for this. And then now some other cases in which the epithelium really makes a difference. So I'm going to make it tricky because some of these are the other eye of an ectasia and some others are not. So it's not easy, all right? So this is one eye. So this is, here I'm showing everything. So here you have the epithelium, you have, I'm also showing the epithelial pattern, everything. So do you think this is a ectasia or not? This is a tricky one, it's complex. To make it nice, obviously I couldn't show the images bigger because otherwise it looks wrong. Yes? Let me show, it's very difficult to go here. This one, this is the epithelial map. So it's going to be tangential, corneal thickness, anterior elevation, posterior elevation, epithelial map, and keratoscopy. This is all the way, I always show cases like this. You think it's ectasia?
See, I always right mouse click on the epithelium and normalize the scale. Because right now you've got green and green.
Yeah.
And we'd like to see some more delete.
But what I can show you, this is showing the same. You see the pattern standard deviation.
Well, that's right. And that's why if you normalize the epithelium, you would see that straight away without the pattern deviation. But you can see on the bottom left, anterior and posterior, the elevation's similar. And if you correlate it with where the pattern deviation is, that, by the way, is the exact purpose of this display.
Yeah.
It's specifically so that you can look at the back surface and the pattern deviation of the epithelium at the same time.
So you think it's ectasia or it's suspicious? It could, right?
I mean, I don't know about the color scale and the pattern deviation. That is thinner.
Yeah.
Right? Yeah. Okay.
Yeah. Yes. Yes. Exactly. So you were right. So this is the fellow eye. So these are very advanced keratoconus in which you know that sometimes you get a thick epithelium when it's super, super advanced on the colon. So this other eye went to dull. So this is a suspicious eye in which we can show that actually the epithelium was able to show some mild abnormalities. But again, I always want to show you that the posterior elevation is where the epithelium is thin. So there is no way you have change in the epithelium and the posterior elevation is absolutely normal because it has to change. The epithelium doesn't change alone. It changes after the stroke.
Riccardo, again, I just made the same comment, but it really is, for me, I never use the anterior elevation. I think it's completely useless. And I always use the posterior curvature because I can compare to the anterior curvature. And I can really compare, and if they are completely incongruent, then I know it's a problem. I know sometimes the epithelium changes or whatever. But if I have a posterior abnormality with an anterior being normal, that's definitely, you know what I mean, something.
Curvature doesn't help you much with the astigmatism because the nice thing of elevation is that when you have astigmatism, it's depressed.
But elevation is referenced especially if it suffers from angle alpha. You know how much elevation suffers from angle alpha. And CSU tried to account for the tilt, yet it suffers much more than the curvature. And CSU always tells you the same. That's the only reason why I always say if you look at both, it helps more than looking at the anterior elevation, for instance, which I don't think you would ever add any information.
No, actually, I will show you a case. The next one does. In the next one, it will.
Well, it doesn't because if you look at the epithelium, then if you have the epithelial map, you don't really need the anterior elevation.
No, because then you know how much epithelial thickening there is compared to anterior elevation. For example, in this case here, you see that the amount of thickening, this one, the amount of anterior elevation was not exactly the same as epithelial thickness. So you still know that there is epithelial thickening beyond the anterior elevation.
Yeah, but it doesn't help you in the diagnosis.
In the diagnosis, not, but in the treatment, yes.
Yeah, I'm talking about diagnosis.
Yeah. So this is case 4. What do you think about this one? So is this an ectasia or not? It's not, right? So here, epithelium really does make a difference a lot, because you see a thickening of the epithelium where it's supposed to be thin. And this is a warpage. So it's a patient that was using a lot of contact lens, inferior thickening, and so this is really making a difference. And also what you see is that you have a thickening in the epithelium where the posterior elevation is depressed, because it's not in the same place. If you look here, so the thickening is here and the depression is here. So it's what is called red on blue.
Yeah, that was here.
You know, the color scales are not helping you because it's green and green. And if you normalize the scale, you'd see more relief.
Yeah.
I never look at the maps on a default scale. The epithelium, I always normalize before I look at it. In fact, I've talked to Francesco about making it a default that the epithelium map is always normalized, because it's not the thickness, it's not the actual value that you care about, it's the pattern. So that's all you're looking for, is the pattern, right?
So this one is, I'm telling you, that is the only case I've seen in my life like this. So do we all agree that this is a patient with keratoconus? No. You have a serious. You have a serious and you're not able to measure the OCT. Do we all agree that this is a keratoconus? It's a clear diagnosis. Now, there is a 40 microns of posterior elevation in the right. Look. The pachymetry is around 450.
Posterior Gaussian.
Well, I don't have the MS39, so I cannot show you everything, obviously. But this, I mean, do we all agree that this is a keratoconus? With posterior elevation, anterior elevation, decreased thickness is a keratoconus. There is no doubt.
Yeah, it could be, it could be Fuchs.
No, then the endothelium is not.
Okay, I mean, yeah.
It's a strange case, I'm telling you. So I do not, because I wanted to show you that then I did the MS39 5 times to this lady. And this is the epithelial thickness. So she has an extremely thick epithelium while she has keratoconus. So the only thing that she has extremely abnormal is that, I don't know why, she has 8 millimeters of mercury of pressure without drops. She never had glaucoma. She has 8 millimeters of mercury. So this, and she had in one eye cross-linking, but both eyes are thick. It's the first time in my life I've seen a keratoconus with an extremely thick epithelium, but it's very low depression. I've done it 5 times, to be sure.
I've seen some go with thick epithelium where they lost tissue in the center because of repeated scar. So when
no, but it's not those cases that you lose. It's a from the point of view of the stroma, it's mild, the keratoconus. It's not advanced. You can also see. I wanted to discuss.
In this case, and the way that you can get unexpected epithelial patterns is the eyelids. And if you look at the eyelids on this image, you can see she's got quite a high riding lower lid, and it can actually bunch up the epithelium. And you can see, I mean, we've shown cases like this in courses, right, where the epithelium is thick, almost in a band.
Yeah.
And just above where the lower lid, rests. But yeah, that is interesting. That is interesting.
Like 8 years before.
Wait a minute. Oh, wait a minute. Wait a minute.
One eye. Only one eye.
Yeah, which eye was cross-linked?
That's a big question. I'm pretty sure. I think it's the right one.
Yeah. So,
I think it's the right.
We published this paper many years ago showing that the corneal curvature can be stable from 2 years to 3 years after cross-linking, but the epithelium thickens from 2 years to 3 years in that spot. And that is proof that the cross-linking is still flattening the cone,
while
the epithelium is filling the increased flattening. And, I was going to ask Farhad, but he's gone. But this idea of topographic cross-linking, to me, is very, very, very worrisome, because cross-linking is the Christmas present that keeps on giving. And we all have seen persistent hypermetropization after cross-linking. And so if you're going to do asymmetric cross-linking, which is very high energy, localized, what's going to happen to these patients if they continue to flatten focally, and they're just going to get more and more and more irregular? So, you know, all of these, so there's the stromal surface that we want to see on the MS-39. And, you know, you can do a stromal thickness map, and you can do difference maps of the stroma.
Well, obviously, this was the first time she came to us, so we don't have that differential.
Oh, good case. That's a great case.
Thank you. So it's 9 o'clock, so I will not go.